Welcome to the topic hypertension. Blood pressure and hypertension is the most common type of the cardiovascular disease, and it is half the affected population who is not aware that they have the hypertension. It is a silent killer, and it is the force of the blood that pushes against the walls of the arteries. That's why it is putting the pressure on the arteries. It's called as the blood pressure. Actually, the blood pressure is caused by the pumping action of the heart, and failure to treat the hypertension can lead to stroke, heart failure, or myocardial infarction. So hypertension, actually, the blood pressure changes throughout the day, but when it remains high all the time, then it is termed as the hypertension. Otherwise, when we walk, the blood pressure is high. When we are relaxing, the blood pressure is low. But if it remains high all day long, all night long, that is called as hypertension. Then prolonged hypertension leads to the damaged blood vessels and their organs. It can damage the kidneys. It can cause dementia and erectile dysfunction as well. So there are several risk factors. They contribute to the development of the hypertension, and some of them are modifiable only. Like we have some non-modifiables. It includes age, race, gender, and family history. We have modifiables like smoking, obesity, poor dietary habits, sedentary lifestyle, high alcohol consumption, chronic stress, lack of exercise, and the high salt intake. So we have to be careful for those things. Then hypertension can be the essential hypertension, which cannot be easily identifiable of the essential hypertension. And 90% of the cases, they have the essential hypertension. But if we talk about the secondary hypertension, in the secondary hypertension, the cause is known and the adrenal gland problems or the renal artery issues are there. Taking the blood pressure regularly will improve the drug and the lifestyle compliance because the effects are visualized. So the primary factors, they are responsible for the blood pressure and the cardiac output is the resistance of the small arteries and the blood volume. So we can see here from the low risk age per every 5 years, it is going to increase. Then we have only get 2 comorbidities or sometimes 2 or more. Then if the BMI is increased, and then finally is the cyanotic heart disease, which leads to the high risk. Then there are few definitions. Number 1 is cardiac output. So the volume of the blood pumped per minute is called as the cardiac output. It is affected by the heart rate and as well the stroke volume. So CO is the cardiac output, which is equal to the heart rate times stroke volume. If the heart rate increases, the cardiac output increases, and therefore the blood pressure also increases. Then what is peripheral resistance? The amount of resistance or the friction within the blood vessels is called as the peripheral resistance, and due to the diameter of the blood vessels, the smooth muscles and the arteries, they constrict to increase the peripheral resistance and consequently the blood pressure. Then total amount of the blood in the vascular system, we need to calculate that as a blood volume. Then average person maintains a relatively constant blood volume of approximately 5 liters, and it can be changed with certain regulatory factors or certain disease states. Blood pressure is now divided into, we just learned 3 different things, which becomes the primary factors, they affect the blood pressure. Blood volume, peripheral resistance, diameter of arterioles, and the cardiac output. Many nervous and the hormonal factors, they help keep the blood pressure within the normal limits. So the blood pressure is controlled by the actions of the cardiovascular system and the kidneys. So what happened? If the blood pressure is increased, there are 2 things happen. Either the compensatory action by the cardiovascular system or the compensatory action by the kidneys will be done. If the kidneys is doing the compensatory action, the urine output will be increased, then blood volume will decrease and the blood pressure returns to the normal. So one thing is we can give the drugs to maintain this mechanism of action. We will give some drugs which will act on the kidneys, they'll increase the urine output, decrease the blood volume, and the blood pressure will return to the normal. On the other side, the compensatory action of the cardiovascular system, we will try to either give some medications for vasodilation will decrease the stroke volume, decrease the heart rate, and it will decrease the cardiac output, and the blood pressure returns to the normal. So these are different ways, or we make the drugs for controlling by these mechanism of actions. Then there are some hormonal and nervous factors influencing the blood pressure as well. For example, this is one adrenal gland on the top of the kidney. The adrenal gland will secrete the aldosterone hormone, which will go into the body, and in the renin gets converted the angiotensin 1 from the liver into angiotensin 2 in the lungs. So it is converting. Aldosterone is activated from adrenal gland. Then in the renin will convert the angiotensin 1 from the liver to angiotensin 2 in the lungs. Then it will go up there in the blood vessels in arterioles. From the other side, the adrenal gland will increase or give out the epinephrine and norepinephrine, and it will also go and attack on the arteriole. Again, the norepinephrine from the vasomotor center in the medulla, it is also doing the same thing and going back to the baroreceptor. So all that cycle that is going to be working there, it is mainly doing the vasoconstriction here. The kidney is the affected portion in the hypertension, and then the renin is affecting on the kidney, it will change the blood volume. So these are some hormonal factors in our body in which epinephrine, norepinephrine, and aldosterone, these are the hormones. Antidiuretic hormone is the hormone. Hypothalamus plays the part which releases the ADH, and kidney releases the renin hormone, and then there will be the change in the blood volume. Now, what is the renin-angiotensin-aldosterone system, which is called as Ra system? So what happened from the liver? It is constantly producing the angiotensinogen in plasma. And from the kidney, it is produces in response to low BP, the renin is produced. Whenever our body gets high blood pressure, so automatically our kidney will release the renin to reduce the blood pressure. Other side, the liver is constantly producing angiotensinogen in plasma. So the renin will go and convert this angiotensinogen to angiotensin 1. Now from the capillaries, the blood vessels, epithelium, the angiotensin converting enzyme will come, and it will convert the angiotensin 1 to angiotensin 2. Then it will go and it will constrict the arterioles, and the blood pressure is increased. Other side, from the adrenal cortex, the aldosterone is increased, and the increased sodium reabsorption and the increased blood pressure. So that's why our blood pressure is increased in our body. So hypertension is characterized by the consistent elevation of the arterial blood pressure. How do we measure the blood pressure? Systolic pressure is measured in arteries when the ventricles of the heart contract, and the diastolic pressure is measured when the heart is not ejecting the blood. And we always carefully monitor the pre-hypertension stages as well. So systolic should be 120, 139. So that is a pre-hypertension thing. Diastolic, when is between 90 to 99, we say there are chances the person can have a hypertension. Then systolic pressure occurs when the heart ejects the blood, creating the high pressure in the arteries, and the diastolic pressure occurs when the heart relaxes and resulting in the less pressure in the arteries. Home blood pressure monitoring is always playing a vital role in the diagnosis of the hypertension, because every day a person can just go outside and go and check it. So every time we should have a sphygmomanometer at the home to check the blood pressure. What is the diagnosis of the hypertension? It's rarely diagnosed on a single blood pressure measurement, because blood pressure can be raised when you're walking, when you're exercising, when you're eating, when you're in stress. So it can go up and down during the day. So not a single blood pressure measurement is okay to diagnose the hypertension. But the diagnosis made from a sustained systolic blood pressure of greater than 140 to 159 mmHg, or diastolic pressure of greater than 90 to 99 mmHg after multiple measurements, then made over several clinic visits, that will be considered as a stage 1 hypertension. So every time you do your blood pressure is within this range. Then we can say, yes, it is a stage 1 hypertension. Then we do the hypertension treatment. Stage 1 hypertension treatment can completely be changed with the lifestyle. Lifestyle includes our food, our exercises, our sleeping pattern, all that stuff. Pharmacotherapy for hypertension is required when any one of the following are present, and the other cardiovascular risk factors and the blood pressure when it is greater than any 140/90. So if it's blood pressure 140 then 90, more than that, or any other cardiovascular risk factor, then we have to go with the hypertension pharmacotherapy. Then when the pharmacotherapy is required, we know that the person is having an atherosclerotic disease, even if the blood pressure is normal. For example, previous stroke. So person got a stroke and his blood pressure is showing us normal, but still he needs a pharmacotherapy because we know that he already had a stroke. So there are more chances of having a high blood pressure. If a person had a chronic kidney disease and the blood pressure is 140/90 or greater, we need pharmacotherapy. Person is diabetic and the blood pressure is 130/30 mmHg or greater, person needs pharmacotherapy. And when the normally a blood pressure is greater than 180/110 mmHg, then pharmacotherapy is required. So positive lifestyle changes can definitely reduce the blood pressure and also lessen the need for the medications as well. Now, what are these lifestyle changes comes up? These are the cornerstones of the hypertension prevention and management. Increased exercise, like walk 30 minutes a day, reduce weight. If you are obese, high weight, more BMI, then reduce weight. Eating a healthy diet with fruits and vegetables more in your diet and cutting down the fat from your body. Smoking cessation, stopping the smoking, ingesting the less sodium. Every time you don't have to put an extra salt onto your food, or you should take a less sodium salt. Avoiding excessive alcohol consumption. These all will help to maintain the hypertension back to the normal. Now, selection of the specific antihypertensive drugs depends on the severity of the disease. What is the goal of therapy that we are doing? It is to reduce the blood pressure to the normal levels so that the long-term consequences of hypertension may be prevented. We got some primary antihypertensive agents like diuretics, calcium channel blockers, and these agents, they affect the renin-angiotensin-aldosterone system. We have adrenergic agents and the direct-acting vasodilators. Other than that, all these chart is explaining you here. For example, if it's an alpha-2 agonist, this picture is beautifully explaining you about how they act and where they act and how they work. So if we give a drug to the patient, which is alpha-2 agonist, they will decrease the sympathetic impulses from the CNS to the heart and arterioles and causing vasodilation. That's what we need to reduce the blood pressure. If we are using alpha-1 blockers, they will inhibit the sympathetic activation in arterioles, causing the vasodilation. If we are using direct vasodilators, they will act on the smooth muscles of arterioles, again causing vasodilation. Then calcium channel blockers, they will block as the name suggests, they will block the calcium channels in arterial smooth muscles, causing again dilatation. Then angiotensin receptor blockers is going to block the angiotensin conversion, reaching to the receptors, causing vasodilation. So if you have noticed, all these alpha-2 agonists, alpha-1 blockers, direct vasodilators, calcium channel blockers, and angiotensin receptor blockers, they have a common mechanism of action by acting at different places of the body, but causing vasodilation. Then we use some ACE inhibitors. They stop the renin to going to the angiotensin 2. So they block the formation of angiotensin 2, again causing vasodilation, and block the aldosterone secretion, decreasing the blood fluid volume. We use diuretics, which increases the urine output and decreases the fluid volume. Then we also use some beta blockers. They decrease the heart rate and myocardial contractility and reducing the cardiac output. So the common thing to remember is if the blood pressure is high, we need to dilate the blood vessels. We have to give them some vasodilators. Now, diuretics, the first one, they are often the common first choice of the drug for the mild to moderate hypertension. What is the action of diuretic? They increase the amount of the urine produced by the kidneys. Now, when we say diuretic, uretic means increasing urine, and di means like we are increasing the amount of the urine output by the kidneys, widely used in the treatment of hypertension and the heart failure. These are always the first line drugs for treating the hypertension, and they reduce the blood volume through the urinary excretion of the water and electrolytes. What is the mechanism? Mainly, it includes the electrolyte imbalance. So loss of potassium, sodium, and magnesium. Then we have to use the diuretics. Also, the loss of potassium causes the hypokalemia. It can lead to the serious abnormalities in the cardiac rhythm. And thiazides or the loop diuretics are the branches of the diuretics. What is hypovolemia? It is as a side effect of the diuretic. It decreases in the circulating blood volume, can lead to the dehydration. It monitors carefully for dizziness, especially after rising too quickly, or orthostatic hypotension. We have photosensitivity, and the drug enters the skin from the bloodstream and combined with the sunlight. It can cause the chemical changes in the drug, and the new compound triggers a reaction. Now, what is a calcium channel blocker? It always causes the vasodilation, and as its name suggests, it blocks the calcium channels. And these are the important drugs in the treatment of hypertension. Now, calcium channel blockers benefit the effects on the heart and blood vessels by blocking the calcium ions. They are used to treat a number of the cardiovascular diseases like angina pectoris, cardiac dysarrhythmias, and hypertension. Then, contraction of the muscle is regulated by the amount of calcium ions inside the muscle cells, and the contraction occurs when the calcium enters the cell through the channels in the plasma membrane. So this is again mechanism of action of calcium channels. As the name is suggesting, it is stopping the entry of the calcium into the channels, and they stop the dilation. Now, CCBs, like calcium channel blockers, they block these channels to prevent the calcium ion from entering into the cell. They inhibit the muscular contraction, and the low doses cause the dilation in the arterioles, and they decrease the blood pressure. Then, some CCBs are selective for calcium channels in arterioles. For example, the drug name is nifedipine. Others, they affect the channels in both arterioles and the cardiac muscles. For example, verapamil. So nifedipine and verapamil are the two drugs as a calcium channel blockers. Some calcium channel blockers are selective for calcium channels in arterioles like nifedipine, and others affect the channels in both arterioles and the cardiac muscles. It is verapamil. Now, blocking the renin-angiotensin-aldosterone pathway, it can lead to decrease in blood pressure again, as we see in the picture. So what are the drugs that affect the RAS system? One of the primary homeostatic mechanisms, they are controlling the blood pressure and the fluid balance in the body, and the drugs that modify the RAAS, decrease the blood pressure and increase the urine volume. They are always used to treat the number of cardiovascular diseases like heart failure, hypertension, and myocardial infarction. They block the angiotensin II once it is formed, thus decreasing the blood pressure through two mechanisms. So dilating the arteries and affecting the adrenal gland, causing the increased sodium secretion. What are the side effects of these drugs? Like ACE inhibitors, what causes? Persistent cough, postural hypotension, acute hypersensitivity, or angioedema. Now, angiotensin II receptor blocker. If a person is having a persistent cough from the ACE inhibitor, then we have to stop that medication, and the substitute for that medication is angiotensin II receptor blocker. It causes cough, but not the persistent cough. It is less than with the ACE inhibitors, and hyperkalemia occurs, dizziness occurs, drowsiness occurs. There are some alpha and beta adrenergic blockers, which are also commonly used to treat the hypertension. We have some adrenergic agents as well. They block the sympathetic flight or flight responses, and they will cause the heart rate to slow, blood pressure to decline, and bronchi to dilate. Then we have some alpha and beta blockers. How they work? So the blockade of alpha-1 receptors in the arterioles are selective and non-selective. So selective blockades, they occur in the heart, and the non-selective occurs on both beta-2, beta-1, and alpha-beta receptors. So stimulations of the alpha-2 receptor in the brainstem centrally acting, and it blocks the peripheral adrenergic neurons. Then we have some direct vasodilators, which lowers the blood pressure by relaxing the arterial smooth muscle. So vasodilators, they affect the vascular smooth muscles, highly effective at lowering the blood pressure. They are not the drug of the first choice. They have many adverse effects. That's why. The adverse effects includes direct vasodilators, but which produces the reflex tachycardia, means increased heart rate. The normal physiological response to sudden decrease in the blood pressure can happen. So what are the key drugs to treat the hypertension in Canada? Number one, angiotensin converting, it's captopril. Enzyme ACE inhibitors, enalapril, lisinopril, perindopril, ramipril, anything that ends with pril. Then a combination drug, ACE inhibitor plus thiazide diuretic is a lisinopril plus hydrochlorothiazide, which can be written as HCTZ. Then we have angiotensin 2 receptor blockers, ARBs, they end with the sartans. So candesartan, irbesartan, losartan, valsartan. Then we have ARB plus thiazide diuretics, irbesartan plus HCTZ or losartan plus HCTZ. Then we have valsartan HCTZ. They can block both alpha and beta receptors like carvedilol, amlodipine. The drugs, they are calcium channel blockers. We did diltiazem, nifedipine, verapamil. Then we have centrally acting alpha-2 adrenergic agents like methyldopa, direct acting vasodilators, it's hydralazine, direct renin inhibitors, aliskiren. For hypertensive crisis, nitroprusside, loop diuretic is furosemide, and non-selective beta-1 and it's propranolol, and beta-2 blocker is the timolol. Potassium sparing and thiazide diuretic combination is spironolactone plus HCTZ, triamytrine plus HCTZ. Potassium sparing diuretic is spironolactone. Selective alpha-1 blocker is doxazosine. Selective beta-1 blocker is atenolol, bisoprolol, metoprolol, ends with lols. Thiazide diuretic is the hydrochlorothiazide. Then what we did in the whole topic, we understand the action of the heart pumping always creates the blood pressure, and the hypertension should be treated or it can lead to the stroke, heart failure, and myocardial infarction. There are modifiable risk factors which should always be addressed, and the blood pressure is always equals to the cardiac output, which is equal to the product for the cardiac output, heart rate, and stroke volume combined with the peripheral resistance. Blood pressure should be controlled by hormonal and the nervous system factors as well. And BP monitoring is vital, so elevation in the arterial blood pressure can be addressed. And the treatment should start with the lifestyle changes first, and then the first choice of the drug is the diuretics alone or in the combination with the other medicines. And the other medicines includes calcium channel blockers, RAS system blockers, alpha and beta adrenergic blockers, and direct vasodilators. That's all for the chapter. Thanks for watching.